Hello students. Till now into cardiovascular pharmacology we have discussed about different drug classes. That includes alpha blocker, beta blocker, combined alpha and beta blockers, centrally acting sympatholytic drugs, vasodilators, calcium channel blockers, diuretic drugs, drugs acting on renin, angiotensin, aldosterone systems like ACE inhibitors, ARBs and many more. So you have overall idea about what are the different drug classes which can be useful for treatment of hypertension and other cardiovascular disorders. In this lecture, we will be mainly focusing on management of hypertension, how we are going to manage a patient of hypertension. So to begin with, just to revise certain aspects of hypertension, hypertension is sustained increase in the blood pressure of more than 140 by 90 mmHg. According to the classification JNC, Joint National Committee, normal blood pressure is less than 120 and less than 80 diastolic. Pre-hypertension is 120 to 139 systolic or 80 to 89 diastolic. Stage 1 hypertension is 140 to 159 systolic blood pressure or 90 to 99 diastolic blood pressure, and stage 2 hypertension is more than 160 mmHg systolic blood pressure or more than or equal to 100 diastolic blood pressure. And it is important to remember these stages of hypertension because treatment modality or drug selection is different for different category of hypertension. And as you all know, it is one of the most significant risk factor for cardiovascular diseases. So hypertension needs proper attention by the physician. First, we have to try to evaluate etiology of the hypertension. Hypertension is of two varieties. First is essential hypertension, which happens into more than 90% of cases of hypertension, where hereditary and lifestyle related causes are most important. And there is secondary hypertension, which accounts for only less than 10% of cases. Common causes for development of secondary hypertension, which means there is some underlying other disease which precipitate hypertension or which present as hypertension. These common diseases are chronic kidney diseases, renovascular diseases. There are certain other causes like use of some prescription drugs, use of drug of abuse like cocaine, etc. There are certain natural products, certain food product and certain industrial chemical would lead to development of hypertension. So thorough history taking is essential for ruling out all these components. Here is the list of secondary causes of hypertension. Diseases include chronic kidney disease, Cushing syndrome, coarctation of aorta, obstructive sleep apnea, parathyroid disease, pheochromocytoma, primary aldosteronism, renovascular disease and thyroid diseases. There are certain drugs which causes hypertension as a side effect. Drugs like sympathomimetic, that is amphetamine, sibutramine, certain corticosteroids, cyclosporine, nasal decongestant like pseudoephedrine and phenylephrine, ergot alkaloids, erythropoietin, estrogen containing oral contraceptive pills and NSAIDs can cause hypertension as a side effect. There are certain drug of abuse or street drugs and other products like cocaine and cocaine withdrawal, nicotine and nicotine withdrawal, anabolic steroids, narcotic withdrawal, St. John's wort. They produces hypertension, and food substances like alcohol and sodium can produce hypertension. And why it is important to treat hypertension? Because hypertension can lead to target organ damage. What happens as a consequence of hypertension? There is increase in the afterload. Afterload increases, which means there is systolic dysfunction, left ventricular hypertrophy and increased myocardial oxygen demand. Systolic dysfunction and left ventricular hypertrophy would lead to diastolic dysfunction and altogether can lead to heart failure. Heart goes into permanent failure. Because of the increase in the afterload, there is increase in the myocardial oxygen demand because heart has to pump against more resistance. and that would contribute to development of myocardial ischemia or infarction. Untreated hypertension can lead to arterial damage. There is accelerated atherosclerosis. If the atherosclerosis happens into coronary vessel, it narrows the lumen of the coronary blood vessels and decrease myocardial oxygen supply. That would lead to myocardial ischemia and infarction. If atherosclerosis affects the cerebral vessels, that would lead to ischemic stroke. If atherosclerosis affects the aorta, there would be aneurysm and dissection of the aorta. Arterial damage would lead to weakness of the vessel wall. If the vessel wall weakens into cerebral vessel, that would lead to hemorrhagic stroke. If it is renal blood vessel, then nephrosclerosis and renal failure, and if it is ophthalmic blood vessel, there is retinopathy. So untreated hypertension can damage the heart. It produces heart failure, myocardial infarction, myocardial ischemia, aortic aneurysm, which is a life-threatening complication, hemorrhagic stroke, paralysis, renal damage, brain damage, renal damage, and eyes damage. So these are the target essential end organ damage which we need to prevent. That is why even if the patient is asymptomatic, hypertension is required to be treated by the physician. So what is the goal of therapy? Aim of the treatment are: first is to maintain the BP as normal as possible, that is less than 140/90. Prevent or reduced end organ damage, that is damage to eye, kidney and heart and brain should be prevented. And improve the quality of the life of the patients of hypertension. More importantly, the hypertension therapy is to be taken lifelong. So therapy should be designed in a cost-effective manner so that patient can continue taking the drug lifelong. Before starting the treatment, there are certain pre-treatment evaluation which are essential into all the patients of hypertension. This pre-treatment evaluation include multiple reading in supine and standing position, assess for target organ damage, which include detailed history and physical examination. For kidney functional status, you go for the urine examination, serum creatinine level and measurement of electrolyte levels. For evaluation of the heart functioning, advise electrocardiogram, ECG and X-ray chest, and fundoscopic examination for assessing the status of the retinal blood vessels. That will be the baseline evaluation for the target organ damage. Assess for the other cardiovascular risk factors like history of alcohol drinking, history of smoking, comorbidities like diabetes, hyperlipidemia, etc. And if they are there, they also require treatment simultaneously. Just this is the revision of the classification. Normal is less than 120 and less than 80, where recommendation is that you recheck into 2 years. High normal or pre-hypertensive patients 120 to 139 systolic or 80 to 89 diastolic, where recheck in every 6 months is advisable. For mild hypertension 140 to 159, confirm and treat in 2 months. Moderate hypertension 160 to 179 and 100 to 109, treat within 1 month. Severe hypertension 180 to 209 or 1110 to 119, treat within week. And more than 210 and more than 120, treat immediately. And here this is a common terminology, mild, moderate, severe, which is routinely practiced, and they coincide with the stage 1 and 2 of the JNC 7 classification. Classification of the hypertension is usually changing every year, so it is always better to refer to latest JNC classification for the staging of hypertension. Now we start with the treatment. Before deciding the treatment, we should set a target blood pressure. Target blood pressure is the blood pressure which will reduce the morbidity and mortality. Select the drug therapy based on evidence demonstrating the risk reduction. For most patients of general prevention, less than 140/90 should be target BP. But if patient is known case of cardiovascular disorders or coronary artery disease like MI, myocardial infarction, stable angina, unstable angina, patient is suffering from non-coronary atherosclerotic vascular diseases like ischemic stroke, transient ischemic attack, peripheral arterial disease, abdominal aortic aneurysm, diabetes, or significant chronic kidney disease, then the target blood pressure is less than 130/80 mmHg. And if patient is suffering from coexisting left ventricular dysfunction, then target BP is less than 120/80. What is meaning of target blood pressure? This is the blood pressure you want to achieve with the drug therapy. For treatment of hypertension, always there is combination of non-pharmacological measures and pharmacological measure. But whatever measures you choose, this should be your end result of the blood pressure. Let's discuss lifestyle modification or non-pharmacological measures first. If patient is obese, advise the patient to weight loss. Maintain the normal body weight, that is body mass index, between 18.5 to 24.9 kg per meter square. That is responsible for approximate reduction in the systolic blood pressure is 5 to 20 per 10 kg weight loss. If patient loses 10 kg, then systolic blood pressure reduces by 5 to 20 mmHg. DASH type of dietary pattern, which is a special diet advised by the dietitian. Consume a diet which is rich in fruits, vegetables, and low fat dairy products with a reduced content of saturated and total fat. They reduce the systolic blood pressure by 8 to 14 mmHg. Most important is reduce salt intake. You must have heard that all the patients of hypertension are advised to take low amount of salt into diet. Reduce daily dietary sodium intake as much as possible. Ideally up to 64 millimole per day, that is 1.5 gram per day sodium is sufficient, or 3.8 gram per day of sodium chloride. This reduction would cause systolic blood pressure down by 2 to 8 mmHg. Physical activity, regular aerobic physical exercise at least 30 minutes per day and most days of the week can reduce the blood pressure for 4 to 9. And moderation of alcohol intake, limit the consumption of alcohol to 2 drinks per day in men and 1 drink per day in women and lighter weight person. That would reduce the blood pressure by 2 to 4 mmHg. So these are the lifestyle modification. You advise the patient to lose weight, proper dietary modification, low sodium intake, avoid alcohol, and regular physical exercise. So to summarize, weight reduction into obese patients, restriction of salt consumption to 4 to 6 gram per day, that is sodium of 2 to 3 grams per day, increased dietary potassium consumption, physical exercise of like brisk walking for 30 minutes per day for 5 days a week, cessation of alcohol and smoking, yoga and mental relaxation exercise can be helpful for reducing the stress, which can be one of the major cause for development of hypertension. Most important is that you try all these measures for 2 months continuously in mild hypertensive patient and then continue for lifetime along with the medication. Some of the patient, around 20 to 30% of patient would be controlled with lifestyle modification only and they does not require drug therapy for the hypertension. So you try to measure for 2 months and if patient is not improved, then you start with the drug therapy and along with the lifestyle modification. So you begin with the lifestyle modification, not at goal blood pressure of 140 by 90 mmHg or less than 130 by 80 mmHg for those with diabetes or chronic kidney disease. Then you initiate the drug therapy or drug choices. Initial drug choices are without compelling indications and with compelling indication. Without compelling indications, for stage 1 hypertension, first choice is thiazide diuretic, second choice is AC inhibitors, ARB, beta blockers or calcium channel blockers. And for stage 2 hypertension, two drug combination is required, usually thiazide with AC inhibitors or beta blockers or calcium channel blockers. A, B, C, D, AC inhibitors, beta blockers, calcium channel blockers and diuretic. These are the first line therapy for hypertension. And with compelling indication, you have to choose the drug accordingly. Like if patient is hypertensive with benign prostatic hyperplasia, then alpha blocker is drug of first choice. If patient is hypertensive with angina pectoris, then beta blockers is to be preferred likewise. If still not at the goal, optimize the dosage or add additional drugs until the goal blood pressure is achieved. Consider consultation with hypertension specialist for such kind of patients. Now we see the principles of drug therapy. First is to keep the blood pressure as normal as possible, that is 140/90. For diabetic, ischemic heart disease and chronic renal failure patient, it is 130/80. For basic principle for the antihypertensive therapy is you start the slow and go slow. Never hurry to start an antihypertensive therapy and you increase the dose gradually. Drug will take 1 month to show its proper therapeutic effect. It is not like that you start the drug therapy and then the next day you will see the complete pharmacological response. To establish the complete pharmacological response, there will be 1 month time. Do not change the drug until good reason to do so. Don't stop the antihypertensive drug suddenly, especially beta blocker, because of the receptor sensitization phenomena. If there is no effect, then change to other class or combination. And when you are using combination, it is always preferable to have one drug as thiazide diuretic. Side effect develops, then change to other class or combination therapy. So choice of drug. In market, there are various safe and effective antihypertensive are available. There are so many classes of drug and in every class there are so many number of drugs. Like in beta blockers, we have cardioselective beta blockers and non-selective beta blockers. Among the beta blockers, atenolol, metoprolol and many more are there in market. And that is true with almost all the drugs. Study shows that ABCD have the same efficacy and safety except in certain patient group. This ABCD stands for A stands for AC inhibitors, B stands for beta blocker, C stands for calcium channel blocker and D stands for diuretic. AC inhibitors, beta blockers, calcium channel blockers and diuretics. Hence, the approach is to be tailor-made for each patient. Meta-analysis of the clinical trial shows that low-dose thiazide diuretic is first choice and it is also a cost-effective option. Now we start with management with drugs. Start the therapy with the low dose of one agent only. Usually start with the monotherapy. If BP is not controlled, then increase the dose in small increments. That is, start low and go slow. If blood pressure is still not controlled, then you implement combination therapy. Add a drug from different group which is synergistic. Ideally, one of the drug in combination should be diuretic. Now we go in or revise a bit about this ABCD class. That is AC inhibitors and angiotensin 1 receptor blockers. They are useful in high renin and low salt intake patient, into young and active patient. They are drug of choice into diabetes and coexisting nephropathy, for angina and post-MI patient and congestive heart failure patient, left ventricular failure patients, gout, peripheral vascular disease and dyslipidemia. But most important to remember is when not to use AC inhibitor. They should not be used for bilateral renal artery stenosis. It is completely contraindicated. teratogenic drug, so should not be given into pregnancy, and they produce hyperkalemia as a side effect which needs monitoring. Caution is required along with high dose diuretics. In pre-existing dry cough is one of the cautious condition because one of the side effect of ACE inhibitors is dry cough. Now there is a B stands for beta adrenergic blocker drugs. They are useful in IHD and post-MI patients, anxiety and tachycardia, thyrotoxicosis, tense young patients, migraine and mitral valve prolapse, high renin hypertension, and in pregnancy beta 1 blockers and beta blockers with increasing intrinsic sympathomimetic activity are considered as safe and can be used in emergency conditions. Where not to use beta blocker? Into the patients of heart failure because they further suppress the heart, especially decompensated heart failure, bradycardia and heart block, asthma and peripheral vascular diseases, and into diabetic patient because of the phenomena of hyperglycemic unawareness. Asthma and peripheral vascular disease may get aggravated with beta blockers. Abnormal lipid profile because they produces dyslipidemia. Depression. Other drugs, C stands for calcium channel blockers. They are useful in elderly, low renin patient and stiff arteries. They are useful for isolated systolic hypertension, for physically and mentally active patient, drug of choice for asthma and COPD patient, and Raynaud's disease, and they are safely given into pregnancy. But they should not be used along with verapamil and diltiazem. They should not be given into patients of CHF, sick sinus syndrome and heart block patient and those who are having beta blockers because they all suppresses the heart together. And dihydropyridine should not be used into patient of ischemic heart disease and left ventricular hypertension, benign prostatic hyperplasia and GERD because they can get worsen with the calcium channel blockers. D stands for diuretics. They are useful in elderly patient, isolated systolic hypertension and congestive heart failure, obese and volume overload patient, renal diseases with sodium retention, and where you want to give low cost therapy, then thiazide is drug of choice. They are to be avoided into young active patient, diabetes and family history of diabetes because all the diuretic produces hyperglycemia side effect, gout or family history of gout because they precipitate gout or attack and hyperuricemia, abnormal lipid profile and pregnancy related hypertension. Let's come to selection of antihypertensive drugs. Till now we have discussed about A, B, C and D 4 classes of drug. How to select antihypertensive drug with compelling indication? If patient is having associated problems like migraine, then beta blockers and calcium channel blockers are preferred drug because they are helpful as a prophylactic for migraine also. For depression, diuretic ACE inhibitors and CCB, and not recommended drugs are centrally acting sympatholytics because they produces depression as a side effect. For asthma patient, calcium channel blockers are recommended and beta blocker, especially non-selective one, are contraindicated. For angina pectoris patient, beta blockers and calcium channel blockers are preferred, while hydralazine is contraindicated. Into patients of old MI, beta blockers and ACE inhibitors are preferred and calcium channel blockers are not recommended. For thyrotoxicosis, beta blockers are preferred and vasodilators is to be avoided. For hyperlipidemia, ACE inhibitors and alpha blockers are good choice, while beta blockers and diuretic are not recommended. For diabetes mellitus, ACE inhibitors, ARBs and calcium channel blockers are recommended. For benign prostatic hyperplasia, alpha blockers are given. And for chronic renal disease, ACE inhibitors, ARBs or calcium channel blockers are given. Now we discuss something about use of drug combination in hypertension. Half of the patient in long term need minimum 2 drugs for controlling their blood pressure. An ideal combination should be effectively reducing the blood pressure. They reduce ADR of each other. They should act via different mechanism of action and they assure better compliance. Diuretic can be combined with ACE inhibitors or beta blockers. Beta blockers and calcium channel blockers, methyl dopa and clonidine cannot be combined. So suitable combinations are one drug which should raise the plasma renin activity like diuretic, vasodilators and calcium channel blockers, along with the drug which would reduce plasma renin activity like beta blockers, clonidine and alpha methyl dopa. One drug which causes fluid retention like sympatholytics except beta blockers and vasodilators, with diuretics which causes fluid depletion. Tachycardia caused by vasodilator are better combined with beta blockers which produces bradycardia. Synergistic combination is ACE inhibitors and angiotensin receptor blockers along with diuretic. And dangerous combinations or combination to be avoided are adrenergic blockers with clonidine because they antagonize the action of each other. DHP with diuretic, there is no added advantage. Vasodilators with dihydropyridines or prazosin because they produce similar actions and tachycardia would be seen. Verapamine and diltiazem should not be combined with beta blockers because they both produce bradycardia. Methyl dopa with clonidine or any two drugs from the same class should never be combined because their ADR profile overlaps. Now we come to the management of mild hypertension. You start with the non-pharmacological therapy like weight reduction, salt-restricted diet, dietary modification, reduction in the alcohol consumption, proper sleep, yoga, mental relaxation, regular physical exercise, etc. for 1 to 2 months. Then if patient is not controlled, then you start with the thiazide drug. Hydrochlorothiazide is drug of first choice for all the patients of mild hypertension unless contraindicated. Dose is 25 to 50 mg or alternative drug is chlorthalidone 12.5 to 25 mg. Antihypertensive effect would be seen by around 4 weeks. If age is less than 50, then beta blocker can be used as first choice like atenolol 12.5 to 50 mg. In diabetes or other compelling indication, you choose drug of first choice as discussed in the earlier table. Like in diabetes, ACE inhibitors are first choice. For management of moderate hypertension, combination drug therapy is required like beta blocker plus thiazide, ACE inhibitor plus thiazide, non-pharmacological add-on to the drug therapy. Management of severe and very severe hypertension, they have damaged target organs, so a sudden reduction in the BP may reduce azotemia or coronary insufficiency. That is why sudden reduction is not advisable. Addition of drugs like clonidine or prazosin or hydralazine may be required in very severe cases and it may help. It is considered as a hypertensive crisis and it is treated as an emergency, medical emergency. Patient needs admission into hospital. Then comes hypertension in elderly. Physiological changes into the elderly occurs. That is both diastolic and systolic BP rises with the age. Other risk factors may present simultaneously into elderly patients like beta adrenergic response and plasma renin activity decline with the age, increased peripheral resistance because of the change in the vasculature along with the aging process. Not all elderly hypertensive needs drug treatment. More than 70 years of age usually have some amount of higher blood pressure. Rapid lowering of BP and postural hypotension can be dangerous into this individual. Complex multi-drug regimen should be avoided because they cannot remember complex regimen, would lead to non-compliance. If a drug produces rapid fall in blood pressure and postural hypotension, then patient has tendency to fall down and fracture femur and other complication would be there. Low dose chlorthalidone 12.5 to 25 mg is drug of first choice or hydrochlorothiazide. If needed, add atenolol or amlodipine or ACE inhibitor. Next is isolated systolic hypertension where systolic BP more than 140 mmHg and diastolic less than 90 mmHg. Treat with low dose thiazide or atenolol or amlodipine. How to treat hypertension in pregnancy? If systolic more than 136 mmHg and or diastolic more than 86 mmHg, there are two varieties. One is chronic hypertension, where hypertension was there before the pregnancy. Second is transient hypertension, which is developed after the mid-pregnancy, mild in nature, and BP returns to normal postpartum. And third is preeclampsia, where moderate to severe hypertension is there, which would lead to edema, proteinuria, disturbed liver function, and disturbed coagulation function, and it is a complicated situation. Eclampsia, where moderate to severe hypertension is accompanied with convulsion, and it can be life-threatening for both mother and baby. So, drug of choice for chronic hypertension, 85% of pregnancy may continue without any complication and need treatment to prevent preeclampsia only. Drug preferred is methyl-dopa, which is effective and safe to both mother and baby. Alternative is beta blockers in third trimester because they produce some amount of fetal bradycardia. Nifedipine can be used safely in acute episodes. How to manage eclampsia? First is you hospitalize the patient, bed rest. Antihypertensive drugs are given like IV labetalol or sublingual nifedipine every 30 minutes. Anticonvulsant given is IV magnesium sulfate. If needed, termination of the pregnancy is the only chance to survive the mother and fetus. So with the drugs with hypertension in pregnancy, methyl-dopa is drug of choice. It is traditionally given as 250 mg 4 times a day. Labetalol increasingly preferred over methyl-dopa because of less side effect. Clonidine, it is very limited data available, but it is used mainly into third trimester. Calcium channel blockers, they does not show any major teratogenicity with exposure. Discontinue before labor as they weaken the uterine contraction. Non-selective beta blocker are known to cause low birth weight babies, decreased placental size, neonatal bradycardia and hypoglycemia to the fetus. Diuretic will decrease the blood volume, placental perfusion deficit would be there, and increased risk of fetal wastage and placental infarct, miscarriage and stillbirth are high with the diuretics. AC inhibitors and ARBs are completely contraindicated because they produced major teratogenic side effects. Next comes resistant hypertension. Blood pressure which is not under control despite using 3 antihypertensive including diuretic is classified as resistant hypertension. Reasons could be inadequate drug therapy, continued stress, poor patient compliance, excessive salt intake, excessive smoking and alcohol. Then comes hypertensive crisis. When diastolic blood pressure is more than 120 mmHg and or systolic BP more than 180 mmHg, papilloedema can be present but it is not always present sign. There would be decrease in the renal function, epistaxis, encephalopathy or cerebral hemorrhage. Acute LVF, unstable angina or MI can be precipitated. So how to manage hypertensive crisis? Hospitalize the patient into ICU. Invasive monitoring of BP is required. Else avoid IV drugs. Patient should be in supine position to avoid orthostatic hypotension. Sudden reduction in the BP is hazardous. It may lead to cerebral ischemia, blindness, stroke or MI. So 20% reduction. Every hour 10% reduction is required. So types of hypertensive crises are hypertensive urgencies and hypertensive emergencies. Hypertensive urgencies were high BP with impending complication, which means complication has not started, but you are observing the signs of impending organ damage. Here there is reduction in the blood pressure is required into next 24 to 48 hours. Signs are epistaxis, preeclampsia and diabetic retinopathy. Or hypertensive emergency means high BP with end organ damage has started. Reduce the BP in 1 hour to save the life of the individual. Here the complication would be MI, intracranial hemorrhage, left ventricular failure and eclampsia. And drugs used in hypertensive crises are sodium nitroprusside, which is a arteriovenous dilator, given as 0.25 to 10 microgram per kg IV infusion. Onset of action is immediate, duration is 2 to 3 minutes, but it can produce thiocyanate toxicity. Other is nitroglycerin, 5 to 100 microgram per kg IV infusion. Given onset of action is 2 to 5 minutes, duration lasts for 10 minutes. It is preferred in IHT patients. Others are hydralazine, phenoldopam, labetalol and phentolamine, and they are to be chosen based on the compelling indication. Others are esmolol, nifedipine, nicardipine, enalaprilate, and you should remember this regimen because they can be life-saving for the individual. So last point in the management is drug-induced hypertension. Certain drugs can cause hypertension like hormones, glucocorticoids, testosterone and ethinyl estradiol. Vasoconstrictor drugs like adrenergic drugs, ergot alkaloid, MAO inhibitor drugs, salt retaining drugs like NSAIDs, miscellaneous drugs like bromocriptine, alcohol, caffeine and cyclosporine. And treatment is you discontinue the offending drug and you start with the guidelines of the management of hypertension. So this finishes our discussion on management of hypertension. I hope after understanding this lecture you will be easily able to manage a patient of hypertension walking into your OPD. If you are having any questions, you can ask here into the comment box. Thank you.